this lecture to the YouTube. So you're going to have plenty of questions from there too, and I'm going to pass you, okay?
Okay.
So we are already on YouTube from now on. So I'm going to introduce you all to the people. We have 2,000 people enrolled for this Congress, online Congress. Some are attending at the same time as us, and the others are watching afterwards. So I'm going to formally start it from now on. So good evening, everybody. Good morning for people in Korea. Good evening here in Brazil and in the USA. I'm Dr. João Nicoluzzi. I'm a physician from Hospital Angelina Caron. It's a hospital in the city of Curitiba in the south of Brazil. This Congress is the HPB 21, an event destined to promote hepato and pancreatic surgery as transplantation as well. I would like to thank the Brazilian College of HPB Surgery, Brazilian Society of Oncologic Surgery, medical students associations who have been supporting us, and especially to Angelina Caron Hospital, which is the hospital who's been supporting us from the very beginning 21 years ago. And also to the more than 2,000 people enrolled for this online Congress as well. So I would like to introduce you the speakers. So first, Professor Luiz Carneiro, who is the director of the transplantation service at USP, which is the most important hospital probably in Brazil, if not in Latin America. Professor Carneiro, as I like to say, is a legend on Latin American transplantation and the most important person and personality in liver transplantation in Brazil for sure. Welcome here, Professor Carneiro. Thank you very much for being here with us.
Thank you for introduction. It's not so true, but thank you.
True, yes, it is. You're very humble. And the second lecturer, the second speaker is Thiago Beduschi, Brazilian surgeon, who's been a long time in the States, and nowadays is the president director of the University of Florida Health Abdominal Transplant Program at Gainesville, Florida, USA. Thank you very much indeed for being with us tonight. It's a great job that you're doing in the States, especially with your liver program in the short term as well for the multivisceral as well. Welcome here tonight.
Thank you very much, Dr. Nicoluzzi. It's a pleasure to be here, and it's a great pleasure ours to see Professor Carneiro and Professor Ki-Hun, from whom we learn a lot over the years.
Thank you. And for the lecture, I would like to introduce you all the Professor Kim, who is the director of the Department of Surgery at Asan Medical Center at Ulsan University, Seul, Korea, which nowadays is the most important liver transplantation service in the world, especially for liver-related transplantation. Most of the most interesting advances in liver transplantation and liver surgery were performed there in the last 20 years, like the dual liver transplantation that is going to be shown in the development of very advanced techniques of laparoscopic hepatic resections. Thank you very much indeed for being with us tonight, Professor Ki.
Thank you. Thank you for your kind invitation, and Dr. and João Nicoluzzi. And so, I say thank you to Dr. Luiz Carneiro and Thiago Beduschi. So I think then it's a very valuable time for all surgeons and who are involved in living on liver transplant. So, and also I hope to have a good discussion time after my presentation. Thank you.
Thank you. So if you allow me to do so, Professor Kim, I'm gonna pass your videos that you have previously sent to us. And once they are over, we are going to open to the comments from the speakers. Is that fine to you? Okay, so we're gonna pass the videos.
Hello, my colleagues. I'm Kim from Asan Medical Center. First of all, I'd like to thank my friend Dr. Nicholas for your kind invitation. Today, I'd like to talk about a marginal live donor in living donor liver transplant. I have no conflict of interest. We did 6,700 11 liver transplant from August 1992 to December 2019. Living donor liver transplant occupied 84% of adult liver transplant. So far, there's no donor mortality in my center. To maintain a successful living donor liver transplant program, the living donor safety is of paramount importance. Out of 4,700 living donor hepatectomies over 20 years, there was no donor mortality or serious complication at Asan Medical Center. The current donor morbidity rate at my center is around 1%, even in right living donors. Firstly, I will introduce ABOI. Korea's first case of ABOI pediatric living liver transplant was done in 1996, very early year of our living liver transplant program. But adult programs have started very late, as several starting programs showed promising results, and the numbers of centers and cases have explosively increased. Now, a total of 13 centers are running the ABOI adult LDLT programs and doing more than 140 cases per year. In Asan Medical Center, we performed our first case of ABOI adult LDLT. More than 20% of adult LDLT is ABOI, and we are doing more than 60 cases annually. It means ABOI live donors are a very effective option for live donor pool expansion. The early outcome of ABOI liver transplant was not satisfactory. Most patients were ICU bound and requiring urgent liver transplant because the great fear of hyperacute rejection. Most patients received a very potent desensitization and immunosuppression. Most of them were ineffective and too strong. So many patients died of infectious complications after ABOI and living donor liver transplant. Rituximab starts its action very quickly. It has a long-lasting effect on B cells. Since the rituximab was introduced into the ABOI organ transplantation, the situation has changed dramatically. Comparing survival outcome and case number according to the involvement of desensitization, we can see the big difference. At Asan Medical Center, we performed 357 ABOI adult LDLT from November to %. The 1 and 5 year patient survival rate was 94 and 88% respectively. Those are very comparable to those of ABO compatible adult LDLT in Asan Medical Center. However, it is too early to declare living donor liver transplant. Most cases are manifested by diffuse intrahepatic biliary stricture, so-called the attenuated antibody-mediated rejection, around 2 or 3 months after liver transplant. Half of them would eventually require retransplant in our experience. It significantly affects the long-term survival outcome and life quality of patient. There was a big difference in the patient survival and graft survival rate between patient with or without diffusion intrahepatic biliary stricture. This slide shows an updated Asan Medical Center's protocol of ABY adult LDLT. We don't do splenectomy and local graft infusion by hepatic artery and portal vein anymore. Let's move on to the chronic hepatitis graft. Actually, HCV positive or HBV positive is not recommended to use in LDLT. However, if this infected graft has to be used without any chance, high dose of HepaVic plus anti-HBV drug must be used to maintain over 1,000 internal unit of HVS antibody titer. And next, graft with a benign tumor. There are two reports about this. Using graft with a benign tumor is feasible but needs a long-term follow-up and a larger sample study. Let's move on to the anatomical variation. Analyzing the reason for rejection in 9,000 donor candidates in Asan Medical Center, we found that the majority of them involved inadequate liver volume or hepatic statuses. Anatomical variations accounted for only 1.8%. This means that most anatomical variations were overcome with special surgical expertise. Most of portal vein anomalies except type 4 or other unspecified or rare anomalies are not contraindication for living donor hepatectomy. This figure is illustrating the surgical techniques of Y graft interposition. First, the recipient portal vein, including anterior and posterior sectoral branches with sufficient length, is taken from the explanted liver. Each sectoral branch is connected to each opening on the graft. At the time, the sectoral branch should be folded sufficiently to avoid redundancy, and the rubber tubes are very helpful in making a good alignment. During portal vein anastomosis, we must be careful to avoid redundancy, especially the posterior wall should be folded more to make a tight anastomosis. Y graft interposition has long been accepted as the standard procedure at my center due to low rate of early portal vein stenosis and excellent long-term patency rate. However, even a small alignment error can result in severe stenosis of portal vein. We've had several beginners consecutively make these kind of mistakes. So we've introduced the surgical techniques of conjoined unification venoplasty as a refined alternative to conventional Y graft interposition. This new technique has been accepted at my center as one of the preferred technique options for double portal vein openings. This technique consists of placement of a small vein unification patch. Graft saphenous vein will exaggerate the left portal vein between two portal vein orifices, followed by overlying coverage with a crotch opened autologous portal vein Y graft. As you know, there are so many anatomical variations in the bile duct. In level graft, the biliary anatomy is not troubling in most cases, but there is quite different situation in right lobe. From the viewpoint of bile duct opening number of right lobe graft, anatomic variations can be grouped into these categories. The last case was very rare and required 3 or 4 bile duct anastomosis. Complex biliary anatomy in the donor can result in multiple and small bile duct openings, which confer a higher risk of biliary complication in the recipient as well as in the donor. To avoid unnecessary multiple bile duct openings in the graft and donor bile duct injury, we've been using these rubber band techniques. The size and number of hepatic artery are not a problem if you have an experienced microsurgeon in your team. Nearly all hepatic artery branches can be securely reconstructed regardless of size and number. If native hepatic artery is not available, due to previous operation, tests, injury during highlighted section. Right gastroepiploic artery is one of the most readily usable alternatives, and it is very useful in providing additional inflow. And I will introduce to all living donor liver transplant. When a single graft is not available, two grafts from two living donors could be used to solve the problem of small size graft and donor safety. In 2000, Professor Lee and Asan team performed the first dual living donor liver transplant. 500 dual living donor liver transplants were performed for donor safety, together with adequate graft size. There are various kinds of dual graft. And now I will show you a video clip for dual LDLT. Unfortunately, there was a suitable single donor for this patient, so we decided to perform dual living donor liver transplant using two level of graft to solve the problem of small size graft and donor safety. This is the recipient side, and this is right hepatic artery, right posterior and right anterior. Dissected and taped, and this is left hepatic artery, middle and left, and this is common bile duct here. It is very important to dissect each structural hepatic artery, portal vein, and bile duct maximally and longitudinally. So we have cut the right and left hepatic duct. And this patient has a type 3 anomalous portal vein. So this is right posterior portal vein and right anterior, and here is the left portal vein. And each portal vein is cut. And this is a right hepatic vein, clamped and cut. And this is a middle and left hepatic vein trunk, clamped and cut. Total hepatectomy is made, and suprahepatic venous cover and infrahepatic venous cover are clamped. To maintain good operative field, we usually use extracorporeal bypass system. And this is a left side graft. We are checking the size of portal vein, hepatic artery, and hepatic vein, and bile duct. And firstly, left side graft is implanted orthotopically. Hepatic vein anastomosis is made. And the right side graft is implanted with 100-degree rotation. Also, hepatic vein anastomosis is made. And this is anterior wall. And here is portal vein of recipient side. And left side portal vein anastomosis is made firstly. And posterior and anterior anastomosis is made. And after this, left side graft is reperfused. And right side graft is located with a 180-degree rotation, so hilar structure is reversed, so duct-to-duct anastomosis is made first. And then right-sided anastomosis of portal vein is made. So then right side graft is reperfused, and here is left and right portal vein, and then both hepatic artery are anastomosis under the microscope. Lastly, in summary, ABOI living donors are showing positive impact on donor pool expansion, and outcome of ABOI LDLT has become comparable to that of ABO comparable LDLT, although ABOI LDLT is still immunological risk. Anatomical variation in LDLT could be overcome with refined surgical techniques. If a donor candidate is not eligible due to a donor safety issue or small size graft, dual living donor liver transplant can be an effective solution.
We have a second video now.
Hello, my colleagues. I'm K.H. Kim from Asan Medical Center. First of all, I would like to thank my friend Dr. Luiz for your kind invitation. Today, I would like to talk about laparoscopic living donor hepatectomy. I have no conflict of interest. As far as you know, there are 4 important factors, including adequate graft volume, sufficient inflow, secure bile duct anastomosis, and good outflow. Moreover, the most important thing in living donor liver transplant is the donor safety. According to trends of living donor liver transplant in the United States, the first published report of a live adult LDLT was of one performed in 1997. There was a subsequent exponential growth in adult living donor liver transplant after introducing live graft. However, after donor death in New York in January 2002, adult LDLT decreased dramatically, and also LDLT centers decreased. In the early period of living donor liver transplant, the size of incisions was big, some of which were same with the size of recipient incision. However, the wound of donors looks small after laparoscopic living donor hepatectomy, which is one of the merits in laparoscopic surgery. We did 6,711 liver transplant from August 1992 to December 2019. Living donor liver transplant occupied 84% of adult liver transplant. So far, there's no donor mortality in my center. I did 1,189 laparoscopic liver resection from July 2007 to December 2020. Major hepatectomy accounted for 60%, mainly left and right hepatectomy. Malignant lesion accounted for 64%, mainly HCC, and I have 205 laparoscopic living donor hepatectomy. This slide shows complication rate following open donor hepatectomy in Asan Medical Center. Among 4,395 living donors, the major complication rate showed 1.72%. Interestingly, anatomical variation in donors who had a complication showed 47.6%. So we know anatomical variation may have a higher chance to develop major complication after donor hepatectomy. According to the Korean organ transplantation registry study, the overall biliary and major complication rate were 9.3%, 1.7%, and 1.9% respectively in 832 living donors who underwent open living donor hepatectomy between April 2014 and December 2015. This complication rate in Korea is very similar to the complication rate in the well-experienced liver transplant center of the world. So I always say in the meeting like this, for laparoscope surgery to be beneficial to the living donor, the complication rate should not be worse than open donor hepatectomy. The indication for laparoscope living donor left lateral sectionectomy and left hepatectomy is the same with that for open donor hepatectomy. However, right lobe is different, are very huge, and has a lot of anatomical variation, so we need a reasonable indication for donor safety. And now I will introduce pure laparoscope left lateral sectionectomy. Professor Daniel Chefe performed the world's first successful pure laparoscope living donor hepatectomy, and Professor Olivier Spratt reported the first comparative data between open and laparoscope living donor left lateral sectionectomy, in which laparoscope procedure showed a safe and reproducible technique. I performed the first successful pure laparoscope living donor hepatectomy in the Asian Pacific area in 2008 and reported the comparative data and had a similar conclusion like this. Laparoscope living donor left lateral sectionectomy seemed to be a safe, feasible, and reproducible procedure. This is a very meaningful multicenter study by Olivier. 124 healthy donors undergoing laparoscope living donor left lateral sectionectomy and 300 healthy donors undergoing laparoscope donor nephrectomy were retrospectively analyzed using the Comprehensive Complication Index. The authors concluded laparoscope living donor left lateral sectionectomy is at least a similar short-term donor outcomes as a laparoscope donor nephrectomy, and the laparoscope approach should be considered a new standard practice for retrieval of left lateral section liver graft as it is for kidney donation. This slide shows long-term safety and efficacy of pure laparoscope left lateral sectionectomy in Asan Medical Center. The mean follow-up period was 92.9 and 92.7 months in the open and lap groups. The laparoscope environment, including CO2 gas, whatever, was not associated with the long-term graft survival, and the laparoscope approach for the donors did not adversely affect the corresponding recipient outcome. Sometimes this type of graft with separate two bile ducts can be used safely. Two bile ducts were divided using hemorrhagic clip and ICD technique. Let me show you a video clip. Two bile ducts can be seen under the ICD technique. This is the first one. Hemorrhagic clip is applied. And cut the bile duct, leaving 1 or 2 millimeters above the clip. And this is second one, and also cleavage applied. And cut the bile duct, leaving 1 or 2 millimeters above the clip. I will show you a video clip for pure laparoscope living donor left lateral sectionectomy. 37 male donor. He had a triple anomalies. Type 3-4 vein. Left hepatic artery arises from left gastric artery. The right posterior drain into the left duct. Left coronal ligament is dissected. The left lateral section is mobilized, and left hepatic artery is taped. Middle hepatic artery is identified and taped. Behind this, you can see the left portal vein is taped. Demarcation line is marked. And tracking the middle hepatic vein. Pringle mandible is used. And superficial parenchyma is dissected using analogy device. And size of a particle going to the segment 4 is divided. And lamina to parenchyma transection is continued. And you can see the left hepatic vein is identified. And cystic duct cobra tube is inserted. And rubber marker is placed on the target lesion and check the cholangiogram. More cleavage applied and recheck to confirm the sufficient laminate bile duct and cut the left bile duct, leaving 1 or 2 millimeter above the clip, and laminate plate is clipped and cut. It's time for procurement. Middle hepatic artery, clipped and cut. Left hepatic artery, clipped and cut. And this is left portal vein, is divided using unilateral staple. And also left hepatic vein is divided. And graft is placed into the endobag, retrieved through the suprapubic incision line. This is donor side. At the back table, this is hepatic vein. Venoplasty is made to make a V-line. And this is portal vein and 2 arteries and bile duct. And this is the lesbian side. On POD4, no pathologic finding except the ischemic area on segment 4. I'll show you a video clip for pure laparoscopic leaving the left hepatectomy. 37 female donor, she had only an anomaly. The right posterior duct ran into the common bile duct like this. Left coronal ligament is dissected. This is the left hepatic artery, identified and taped. Left portal vein is also identified and taped. Demarcation is marked after transient clamping of left portal vein and left hepatic artery, checking the middle hepatic vein. Superficial parenchyma is dissected using analogy device. Pringle mandible is used. The portion is dissected using laparoscope CUSA. And this is middle hepatic vein, which is a good landmark. Some size of glycerol particle is clipped and cut. Segment 5, middle hepatic vein branches, clipped and cut. And this is segment 8. And sometimes endostaple is used. and remnant parenchyma is dissected. The celastic tube is passed under the left hepatic vein, left hepatic artery, and also left portal vein for hanging maneuver. And this is cystic duct. Cobra tube is inserted. And lower marker is placed on the target area and check the intraoperative cholangiogram. And hemorrhagic clip is applied and checked to confirm the sufficient remnant bile duct. And this is cystic duct. And cut the left bile duct, leaving 1 or 2 millimeters above the clip, and remnant parenchyma is dissected. It's time for procurement. Left hepatic artery, double clipped and cut. Left portal vein is also double clipped and cut. And this is left and middle hepatic vein trunk is divided using unilateral staple. And graft is placed into the endobag, retrieved through the suprapubic incision line. This is adenoside. Hemostasis and biliostasis are made. A wound at the back table. This is left hepatic vein, this is left portal vein, bile duct, and artery. On POD5, no pathologic findings. Let's move on to the pure laparoscopic living donor right hepatectomy. The original indication for right lobe is needed for safe laparoscopic living donor hepatectomy, maintaining the operative time to be almost similar to open surgery and eliminating or reducing complications. That is as follows: a single longer right hepatic artery, right portal vein, and right bile duct. The few right inferior hepatic vein, less than number 3, and less than 700 grams. According to the Samsung Medical Center's data, after keeping the original indication, the complication rate was decreased from 16.4% to 6.2%. And according to their data, the pure leg group
I'm always home there with them
statistically
music and
higher
them going on,
complication
carrying
rate.
on. A while ago, I go up there for some
Biliary
snacks, I actually
complication
barrel
rate
on.
was also
I
dramatically
can't see anything though,
decreased
especially when I
from
go up there.
11
When I'm here,
to
I can still hang out
1.6%.
water, go down in the well outside, I can't see anything.
5 major centers in
But I want
Korea
to,
enrolled
as my talk was, I'll
575
kill
living
you.
donors
That's the kind
who
of talk to them,
underwent
and I
pure
said,
laparoscopic living donor hepatectomy. There were 39 left lateral section, 25 left lobe, and 511 right lobe. But unfortunately, there was no anatomical variation items in this survey, so now we are collecting the data related to the anatomical complexity. In right lobe graft, a higher complication rate, 8.42%, was shown than left lateral section or left lobe graft. This slide shows analysis of prognostic factors associated with complication of laparoscopic right donor. In multivariate analysis, there were 2 significant factors: operation time and graft weight. The longer the operation time and the more than 700 grams of graft, the higher the complication rate. This slide shows recent data about pure laparoscopic living donor right hepatectomy. In my colleagues, Dr. Zhou's study, we don't have any complication because we've been following the original indication. According to Seoul National University Hong's report, in which ICG cholangiography only used in the bile duct division, a biliary complication rate in recipient showed higher in laparoscope group, and the number of bile duct came out a lot during the laparoscope surgery, contrary to expectation from preoperative MRI scan. As you know, To see the biliary tree clearly on the ICG cholangiograph, the bile duct surrounded by the capsule should be dissected severely, which may be a causative factor of biliary complication to the donors and recipient. ICG cholangiography may miss an aberrant bile duct and may not provide a clean biliary tree. So therefore, it would be better to use both intraoperative cholangiogram, IOC, and ICG cholangiography. I'll show you a video clip of a pure laparoscopic right hepatectomy. 27 female donor has a septal anatomy for a regional indication. And middle and right hepatic vein. This donor has two right inferior hepatic vein and divided. And right hepatic artery is identified and taped. And right portal vein is also identified and taped. The demarcation line is marked. Check the location of middle hepatic vein. Usually use the Pringle maneuver for laparoscopic living donor hepatectomy. Small pedicle is clamped and cut. This is segment 5, middle hepatic vein branching. And this is segment 8, middle hepatic vein branching. For division of right bile duct, we usually use intraoperative cholangiogram, and rubber marker is placed on the target lesion and hemolag cleave is applied, and we check the conformation of a laminoid bile duct. And this small coated duct will be closed at the back table, and right hepatic vein is identified. It's time for procurement. Right hepatic artery clipped and cut. Right portal vein is divided using unilateral staple, and this is right hepatic vein is also divided using unilateral staple. And liver is retributed through the suprapubic incision line at the back table. Inferior hepatic vein and middle hepatic vein branches are reconstructed. And this is the recipient side. On POD5, no pathologic findings. I will show you a video clip for pure laparoscopic extended right hepatectomy for a living donor with unfavorable bile duct. Sometimes I do laparoscopic living donor right hepatectomy beyond the reasonable criteria when donors and their families want strongly to undergo laparoscopic living donor hepatectomy. A 17 female. She had early branching right hepatic artery, abdominal portal vein, and two separate bile ducts. And right liver is immobilized. And inferior hepatic vein is divided. And ibis ligament is dissected and divided. One more inferior hepatic vein is also divided. And this is right hepatic artery, right portal vein, and clamping. And the ICG solution is infused and demarcation line is marked. This is right hepatic artery, right portal vein, and this is bile duct. And checking the middle hepatic vein, and Pringle maneuver is used. And superficial parenchyma is dissected using NOD device, and deep portion is divided using laparoscopic CUSA. And here is left side of middle hepatic vein. Some branch going to the segment 4 is divided. So the hepatic branch is clipped and cut. So one more branch going to the segment 4 is clipped and cut. And this is the root of middle hepatic vein is identified and taped. And this is caudal lobe is dissected. And gold finger is very useful for dissection of remnant hepatic parenchyma. The cystic duct and cobra tube is inserted. Rubber marker is placed on the target area and checked intraoperative cholangiogram. And humeral clip is applied and rechecked to confirm the sufficient remnant bile duct, and cut the right bile duct, leaving 1 or 2 millimeters above the clip, and remnant hilar plate is clipped and divided. And this golden finger is used for hanging maneuver. This is small glycerin particle is clipped and cut, and the bag is applied to reduce ischemic time. It's time for procurement. Firstly, middle hepatic vein is divided, and right hepatic vein identified, and right hepatic artery clipped and cut. Right portal vein is divided using unilateral staple, and this is a right hepatic vein is divided, and graft is retrieved. This hemostasis, biliostasis is made on POD3, no pathology finding. This slide shows a comparative data between laparoscopic major hepatectomy from Asan Medical Center and robotic major hepatectomy from 3 centers, 2 from United States and 1 from Italy. Although this was not an analysis using raw data, laparoscopic hepatectomy showed less open conversion, shorter operative time, and less complication rate. Although these data were not analyzed using PSM yet, laparoscopic group showed a shorter operative time and a less complication rate. A laparoscopic and robotic hepatectomy were performed simultaneously at the live demonstration session of the second ISRS meeting. Laparoscopic left hepatectomy was performed by myself, and robotic left hepatectomy was performed by Dr. Choi at the University. This is a left glycerin particle as clamped using endoblodop, and demarcation line is here, and left coronary ligament is dissected, and infusion of ICG solution, the demarcation lines are marked very clearly. In robotic surgery, individual isolation technique is used. Left hepatic artery is divided, and the location of middle hepatic vein is checked using intraoperative sonogram, and Pringle maneuver is used, and this is left portal vein is taped and clipped and divided, and demarcation line is here, and the parenchyma is dissected using laparoscopic CUSA. In robotic surgery, the energy device is only used for liver parenchyma transection. So actually, laparoscopic CUSA is more comfortable and faster than energy device. A small middle hepatic vein branch is divided. So another branch from middle hepatic vein is divided. And segment 4 middle hepatic vein is clipped and divided, and this is left bile duct is divided using hemlock clip. So you can see the root of middle hepatic vein here. This is left hepatic vein, and this is left Gleason pedicle. Is divided using endo-GIA. So actually you can see the real operative time in the upper right. So this is left hepatic vein is divided. Some bleeding point is sutured. So finally, the laparoscopic left hepatectomy was finished 1.5 hours earlier. In summary, the most important concern in LDLT is donor safety. It is more important to do well without complication than to do it without contraindications. Pure laparoscopic left lateral sectionectomy has become a standard of care for pediatric LDLT. Robotic living door hepatectomy is one of the feasible and safe, minimally invasive surgeries and has a better option in terms of suturing. However, the cost-effectiveness and limited transaction tool should be considered, and there are currently no special advantages for donors compared to laparoscopic donor hepatectomy. Pure laparoscopic major donor hepatectomy is a surgical procedure that requires a high proficiency due to anatomical complexity. Therefore, it is strongly recommended the procedure should be performed carefully by the reasonable criteria in the early stage of performing the surgery and centers with higher complication than open door hepatectomy. Thank you for your kind attention. If you have any question, please contact me via email.
Well, amazing presentation, Professor Kim. Outstanding cases and technique. And now I'm going to leave for Professor Carneiro and Thiago Beduschi to make the discussion with you. Okay?
Thank you for this presentation, Professor Kim. First of all, I would like to congratulate Professor Kim for this both presentations. It's a demonstration of skills and a huge experience, spectacular. The best guarantee of that quality is that when you finish these videos, you believe that you can do this at home easily. And this is a demonstration that this great surgeon make a fantastic surgeon, outstanding. In terms of numbers, it's 20 years in hepatectomy and laparoscopic open, and nowadays a little robotic surgery without mortality. It's fantastic. And in terms of this number shows that the Korean school show us a lot of dedication and care with the patients. All of us know that the patient that receive this kind of surgeries has a spectacular assistance in the postoperative period, and these numbers are due to this care in the postoperative period. And here for us in Brazil, the ABOI, it's almost impossible do the numbers and in the terms of economical numbers. It's increased our bills. I believe that nowadays it's impossible, but if it's impressive to the way the simplification from this post-operative period. Before we saw in Japan, they make total body radiation or radiation and splenectomy, and nowadays you have much more confidence to do this only using drugs that we can have action on B cells. So it's impressive. In terms of technical, it's perfect. I want to ask Professor Ki-Hun. He showed that there is a correlation between graft size and complications, post-operative complication. Which is the minimum size that you use to have a safe evolution in the post-operative? It's always a doubt if you can use 0.8 to 1. How is your goal? And when you decide to make a dual graft instead classical liver donor. And what is your opinion about robotic surgery in the future? If you have no custis involved, what is your opinion about this robotic surgery in the future? Do you believe that worthwhile for us to invest in this, or what's your opinion? You know, you have been in Brazil, you know our reality. What is your way of thinking about this? Thank you for it.
Thank you, Professor and Carnero. So thank you for your compliment. So I'm so humbled. So actually, you have two questions. So first one regarding the graft size. I think it means the GLWR. So actually, in my centers, we are always maintain the over 0.8 GLWR. So this is the mainstay to have a good result and in living donor liver transplant. However, so if a patient, the lesbian side, lesbian has a pure condition, so actually in high MELD score, so then we usually use the over 1.0 GLWR. So yeah, that's the correct and suitable and graft side for a lesbian side, I think. So and second question regarding robotic surgery. So actually, and I think so it's a robotic surgery is one of good option and all surgeons who are involved in the minimally invasive surgery as well as in laparoscopic surgery. However, so far, I don't think any feeling to use the robotic surgery during liver transection anymore. So because the high cost, medical cost, and the limited transaction tool. So as you know, the robotic system has only one tool and energy device. That's the one great limitation because it could size more and comfortable to dissect liver parenchyma anatomically. So that's an great lesion. So of course, then the robotic system has a very convenient system to have a good anastomosis during PPPD, like in hepatojejunal stomy. And however, then during the liver transection, so I don't think there's a good advantage for a surgeon and patient, I think. So in the actual, I'm so actually in the negative thinking, and for a robotic liver resection.
Okay.
But case by case, if surgeons and so convenient to use the robotic system, it's good. It's good. No problem.
Okay. Thank you, sir. Thank you.
Thank you.
Thiago.
Dr. Nicoluzzi, first of all, thank you so much for this opportunity to discuss this topic with two surgeons that have been so important in my career that developed. Professor Carneiro, from the time of Brazil, always like the role model for all of us and leading the University of Sao Paulo, and Professor Ki-Hun, that is probably the best liver surgeon I've ever seen operating. And I had the opportunity to visit his center in 3 occasions, and I had the opportunity to receive his fellows here in the United States. And it's always a pleasure to meet you and to learn from you. So, Professor Ki-Hun, brilliant presentation as usual. And I just have a few comments and questions. So, first of all, the incompatible blood type transplant is really like more than 20% of your volume is incompatible. What's pretty impressive, it is a modality that in the United States, we don't really use. What we do in the United States, even for cadaveric, is the most we do is the blood type A2 to O. That's pretty much compatible. Other than that, is a modality that's not done in the United States. And another point that to prove in liver surgery and even liver transplant, we're still behind the Asia in these modalities. Regarding the grafts with positive serologies that you mentioned, that you do not use or do not recommend and use it, the positive hepatitis C and positive hepatitis B antigen. Is that based on a historical data for safety of the donor, or that with the new treatments for the hepatitis C, would you consider nowadays using, because we virtually cures everyone and we don't see hepatitis C positive anymore? That would be one of the questions. Still regarding the innovation, that when you talk about Asan Medical Center, and I always say that is when you come back from Asan, it's hard to explain what you see there, because people do not believe the pace of work, the volume, the technical level is really, really hard to explain, and you have to go and see with your own eyes. And I think you did not mention in your presentation, you briefly mentioned actually, but I think one of the revolutions in living donor liver transplant was that paper from 1999 about the modified right lobe, that the reconstruction of the V5 and V8. And I remember you saying that Professor Lee before that was a very angry man because the outcomes were not so good. And after that, changed the living donor in the world pretty much, and is the most used graft as adult living donors, the modified technique. And really rare you see someone doing like a right lobe that you do not reconstruct V5 and V8. Regarding our laparoscopic experience, nothing to say. It's like more than 1,000 cases, 200 living donors. The only thing I have to say in that is I had the opportunity to see you doing a right lobe for living donation in 2016. And again, I was in that auditorium that you presented video in 2018 again, and I saw another right lobe for living donation, and I could see the evolution and the way that you evolve with your technique, making it very standard and a safe operation. So it's very, very, very impressive. In the United States, it's very like in the baby steps about the laparoscopic living donors. Living donors as a whole is really like in baby stages, and but United States important. One of your colleagues from Korea and now one of Centro, American Center now is doing more living donors laparoscopic, Professor David Kwon in Cleveland Clinic. And one question about the ICG that you mentioned that because you have to dissect the bile duct more to be able to see it, you may have some worse outcomes. Do you still use it just to have an idea, or you don't use at all in your cases, the ICG? So those are my questions for you, Professor King, about the hepatitis C and the ICG.
Yeah. So actually, then you know that then I'm not a physician about that. And I'm not a hepatologist. So I don't have a lot of knowledge or and so systematic and approach to manage an hep C patient. But then I think that nowadays and we have a very good TAA, direct acting antiviral agent for HCV. So basically, and we don't use the donor who have an HCV positive and HBV positive, and I think in the future, all in the near future, so HCV and positive donors is available for donation in living liver transplant because we have a good drug, a TAA for HCV. So it's okay. It's a good answer for you.
Yeah,
So,
it's good. It's good.
Thank you. So and then another question about the ICG. So and actually there is good and good material to detect and biliary system very conveniently, very fastly. But so and according to my experience, the ICG only using the ICG technique and have some limitation because an ICG technique may miss an aberrant bile duct and may not provide a clean biliary tree. So to see a clean biliary tree under the ICG technique, we should dissect very severely the capsule around the bile duct, which may be a cause of biliary complication after surgery. So I recommend both use the intraoperative cholangiogram using CM and also ICG technique. So I think that it's a good option to dissect a bile duct very clearly and very safely, and that is the good technique for recipient and donor side, I think.
Okay.
It's okay.
Dr. Nicoluzzi, I don't know if you still have time. I know Dr. Kim probably has to go to the war very soon. But I had one more question that if you allow me to do. There was a lot of, much was talked about, historic about living donor of modulation of the portal flow to prevent small for size syndrome, ligation of the splenic artery. There's a lot of studies coming from everywhere. And splenectomy in the past, ligation of the splenic artery, even portal cavo shunt, temporal portal cavo shunt to decrease the portal pressure to below at least 15, to have like 15 millimeters of mercury, to have a lower blood pressure to avoid the hyperflow. What I've seen, I don't know if that's still practice, but I've seen at Asan, after the living donor is performed, intervention radiology coming to the OR to do the embolization of the collaterals. So when you embolize the collaterals, your main portal flow is going to increase. Please, the professor can correct if I'm wrong, but in theory, if you embolize the collaterals, your main portal flow is going to increase. My impression is after you develop at Asan all that perfect or near perfect outflow, reconstructing all the small branches, doing the extension of the right hepatic vein, you're not so concerned about the pressure in the portal system anymore. Is that right?
Yes, and a very good question. So actually, there are many manipulations to overcome the size of small size graft in living liver transplant, so splenectomy or spleen artery ligation and shunt and whatever. So, but according to our as a medical standard experience, so the outflow is very important. So if the portal pressure and portal flow are increased, the outflow is maintained using a good outflow, so it's okay. So actually, then we also do the ligation of all collaterals and to have a good inflow by portal vein. So and also we always do making a good single and a hepatic vein and larger size because then to maintain good outflow is to overcome the small size graft. So our experience, so good outflow is very important to solve the problem of small size graft and regarding of in terms of portal flow, I think.
So outflow is more important than the high part of flux pressure.
Yeah.
In your opinion?
Yes, that's right.
Important point, it's outflow.
Yeah. Yes. Right.
And when you use graft in the outflow, routinely or in the hepatic vein, when you use grafts,
Sorry. Right.
In the hepatic vein, when you use graft in the hepatic vein too, or you show in portal vein the graft to the reconstruction in the portal vein.
Yes, yes. At the back table, once we try to make a good, larger sized hepatic vein using cryopreserved iliac vein from cadaveric donor. So that means that longitudinal incision and the graft saphenous vein graft is surrounded around so created and hepatic vein. So that's one option to make a good, larger sized hepatic vein. So actually, then I respect all Brazilian and transplant surgeons. So because then you are the first successful lingual liver transplant in all of the world. So actually, I think there's and it's my honor to meet each by each. So in this time, so thank you very much. So
thank you.
Dr. Luiz, so do you have any comment? Because I have to go to the outpatient clinic. So.
Oh, okay, sorry. So thank you very much, Kim, for being with us tonight. Morning for you.
Thank you.
Thank you, Professor Carneiro. Thank you, Professor Beduschi as well, and everybody who has attended. Thank you very much indeed, and see you very soon, I hope.
Yeah, thank you.
Thank you.
Hope to see you. Hope to see you, face-to-face meeting. Thank you.
Yeah.
I hope to see you soon.
Bye-bye, see you.
Wellington, send you best regards, Kim.
Thank you.
Wellington.
Obrigado.
Obrigado. Tchau.
Ciao.